Hello, and welcome to today's Q&A discussion on precision oncology practice models. My name is Jessie Modlin, and I will be the moderator for today's discussion. I currently serve as a precision oncology pharmacist at St. Luke's Cancer Institute in Boise, Idaho, and as a member of HOPA's Precision Oncology Initiative Task Force. I am joined today by Christine Walko and Todd Nepper, representing Moffitt Cancer Center, Rachel Elsey at Avera Cancer Institute, Jenny Piccolo from the Madison VA, and Portia Johnson-Williams, founder of PJW Clinical Pharmacy Consulting. We've heard briefly from each of our panelists about their institution's practice models, and in this Q&A session, we're going to explore the different practice models in a little more detail and also hear how their teams are putting them into action, as well as how they're working through some of the challenges that come with it. So whether your institution already has a precision oncology program or you are just getting started in this work, we hope this video series will give you some more insight into the types of practice models that exist and how oncology pharmacists can be integrated into precision oncology workflows. So to start us off, I think all of us on this panel agree that the precision oncology space is moving incredibly fast, and keeping up isn't always easy. So I'd love to start with some more discussion about education. And Portia, I was wondering if you could tell us how you educate and help providers stay current on appropriate biomarker testing across so many different spaces.
Absolutely. I feel like this fits perfectly into the pharmacist's wheelhouse. We're always doing some type of education in services or patient counseling or whatnot. And so I think it's really important to meet the learner where they're at. And so whether it's, starting off with a baseline knowledge and kind of giving them the baseline testing acronyms, or just even like vendors and things of that sort, or different panels per different tumor type, or even tumor agnostic panels, just kind of really understanding what their baseline is and moving on from there. But what I really learned, especially in clinical practice, was a lot of providers were a little bit shy about admitting what they didn't know. And so that sometimes that can hold you back. And so again, really identifying those gaps and figuring out how I can best suit their educational needs. And so whether it's a lunch and learn or a CE presentation or a dinner program or something of that sort, or even an on-demand webinar, is really useful because they don't always have the time during clinical practice to learn. And so maybe on their off time or, during their lunch break is an opportunity to really educate and help them out with that.
Great. Thanks, Portia. And, I think education doesn't stop with our providers. Patient education is equally as important, especially when it comes to navigating consent for biomarker testing and explaining to this patient what this testing entails. And I know there's kind of a big push nationwide to have some of this testing performed reflexively by pathology, which brings in some nuances for the process of patient consent. And I was wondering if you or someone else could shed some light on how consent for testing is being performed.
I can take that one. Traditionally at our institution, genetic counseling has played a really big role in the consenting of patients, especially for the kinds of tests that have a matched normal sample that could potentially shed some light on germline components and what are the, legal and clinical ramifications of those findings for themselves and their families. And, I think they're a really important part of a multidisciplinary team as far as how are we able to use our whole system to do our best job of that. But providers do a great job for part of it. And another way that we've done it is part of a multi-omics platform study. So kind of a broad consent for patients that we can use for different testing types within that umbrella and make sure they get all that education up front and understand. And they're often housed in our standard EHR as other consents are and uploaded to those different, every company has a little bit different way that they have a consent. So that is a little bit of a wrinkle or a twist depending on what vendors you're using for that testing.
Thank you, Rachel. Those were some great insights. And I think it just really highlights how much coordination is required across teams and how many hands are in the mix when it comes to all things biomarker and multi-gene panel testing. Um, I think building on that, another area that is evolving just as quickly is the technology that supports all of this work. And Rachel, could you speak any further on, what clinical decision support tools are in play at your institution right now?
Well, we are brand new to Epic within the month. So we are, I think, just getting to learn what's at the tip of the iceberg. We have used some vendors like Tempest Next for just kind of learning and understanding. But I do think it is really specific on what electronic health record you have and how you can either use that functionality or need to find a way to work through it without that functionality. Another way that we've been really lucky is that we do have a data science team kind of that works with our IT group to help. We're a small team, small but mighty, and being able to collect that data on the back end and have bioinformatics be a part of the housing and being able to have those searchable results to find patients who could benefit from new biomarker driven therapies or be able to find patients who might qualify for clinical trials that are biomarker driven at your institution or others. I think is a great opportunity and worth digging into and having friends in that space to build that team in a different way, a different multidisciplinary team.
And you brought up Epic and that your team is relatively new to that. Is there anyone on the panel that perhaps has been using Epic for a while and could speak to the Epic Genomics module if that is in use?
Todd and I are both chuckling because Moffitt will be switching to Epic and we're in the process. So yeah, that's why we look forward to learning from the answer to that question though.
And we do not have Epic in the VA either. We do have some pretty cool clinical decision support dashboards, however, that I can speak to. So certainly from site to site. So I guess just to back up, so the way that the VA is doing their precision oncology program is through the national oncology program. So even though the patient is being tested at their local facility and the local oncologist is the one discussing that with them, it is paid for out of the national precision oncology program. In addition to that, we provide a lot of education and support. We have a consult team as well as molecular treatment board all on a national level. Because of that, locally, we just have a PDF that is uploaded into a patient's chart and can be challenging to find when you need it. But on a national side, the National Precision Oncology Program does have a group of data scientists and data analysts that have developed some incredible dashboards. So we have dashboards that you can drill down into the different somatic alterations across patients as well as for a specific patient. You can drill down into patient-specific data. You can look at, based on diagnosis at your facility, whether there are patients who have had appropriate somatic testing or still qualify for it, and maybe you're waiting to get a biopsy and stuff, but it helps to identify all of those pieces a little bit more readily for the oncologist as they're working through their patient load for the day. And similarly, we also include hereditary cancer risk and germline genetics in those dashboards as well. So kind of based on that diagnosis, if the patient would be appropriate to send for germline genetics, we can identify that via dashboards as well as somatic genomics.
That's really awesome, Jenny. And I really think it speaks to that integration and sort of having everyone within the VA, connected in that manner. So I want to jump back to Christine really quick because, I know you mentioned you're just getting ready to switch over to Epic, but Moffitt has been in the precision oncology space for a really long time. And I've admired over the years the depth of work that you've published along the way, but I'd really love to hear more how your model has evolved over time. And would you describe it as being, pathology driven, oncology driven, maybe a mixture of both?
That's a great question. And so Todd and I both started in 2014, and we built a database at that time that we are now on our second iteration database that has a lot more capabilities, that was designed with the help of Phil Reisman from Health Informatics at Moffitt Cancer Center, and a lot of input as well from Dr. Kevin Hicks, who works with our group, who has a lot of experience with implementation. And I think what we did was kind of look at the old database and what we liked about it, what we had to change, what we wanted to change, and then at the same time, what were the additional data capabilities that were evolving at Moffitt. We now have the Moffitt Cancer Analytics platform, where the raw data from all of the genetic tests dumps in addition to patient characteristics, HPI, things like that. And so our Precision Medicine Data Mart extracts out the data that we need to do our consults. And then we're able to kind of start the process by pooling that data into our Data Mart, working through the patients. And we also have an interpretative database that we are able to store, like the gene, the drug, the cancer type information. So we're not, you're not writing that up all the time, but you can also tag that to certain clinical trials so that we're able to pull in the biomarker driven clinical trials. And it has helped us scale our team's ability to put in clinical consults and generate that information. We also can go back and do, as Jenny was saying, ask questions about, how many patients with a certain cancer type may have had a certain alteration. Where I use it a lot is I work with patients who have rarer cancer types, certain primary gliomas, sarcomas, have been getting a lot of weird GIST mutations for whatever reason. And I can go into the database and see if we've seen it before. And for example, maybe it wasn't in GIST, but Todd had it in melanoma, and then go and actually see kind of what we said about it before as a starting point for then updating the literature and researching clinical trials, things like that. So I think it's been really helpful that we definitely have tried to evolve with as the technology has moved us forward. And Todd, I don't know if you have any additional comments about that.
Yeah, I mean, not too much. You covered it all that I can think of. I was just kind of thinking back in the history when we started in 2014 and kind of getting the NGS results back like others do, particularly like the external NGS on PDF. And we, specifically had a member of our team who essentially would manually enter one by one each, gene mutation, allele frequency, and kind of all the other information into that kind of database that we built from the ground up. And, it was a full-time job for this individual, but it was kind of probably non-sustainable, particularly as the volumes increase. So, I mean, I think kind of getting to the heart of, the question that you asked previously in terms of mechanisms for dealing with, kind of ingesting in all of the data that comes in through these NGS reports and how important it is no matter where you are, and just kind of having the tools like we have right now that I think, Chris, covered in depth, and I think we covered in our individual video as well. So there's probably some more information there in terms of kind of how that information comes in, and then using that to kind of really get us started when it comes to the interpretations.
And Todd, do you see any role, for AI helping out with just this kind of mass volume of data that we're trying to deal with when we try to pull these reports together?
Yeah, probably. I mean, I think that's a complicated question that everyone is probably dealing with at an institutional level, and probably above that as well, kind of just in the general space in terms of how to integrate AI, which could be super helpful for dealing with large volumes of information, but challenges in terms of both the kind of the sensitivity of the information and not having that into just any old AI model. So kind of having that the clearance process and kind of going through that process through whatever your institution is determined to deal with that. But I think kind of looking forward in the future, just seeing the large volume of information we have and kind of the way things have changed. And in the past, when we would have individual questions on cases or kind of maybe broad retrospective things looking for information, and the amount of kind of manual labor it can take sometimes to do that. So whether it be AI or some other sort of integrated data system for dealing with that information is things are changing for sure. So yeah, I mean, I don't know exactly what the role would be, but there's obviously a lot of interest in that space, and we have institutional committees and working groups to figure that stuff out, and I'm sure others are kind of doing the same.
Yeah, great. Thanks, Todd. I know as these dashboards and models take shape, another layer of complexity that really comes into play with biomarker testing is the use of external lab vendors. So some of us, have opportunities to do some of this testing in-house, but others, I think especially at the community level are, signing into contracts with external lab vendors from across the country. There's some assertive marketing practices. This is a very hot space right now. And I'm wondering if someone, maybe like Rachel, could you tell us how at your institution you vet and, standardize your process for evaluation of external lab vendors?
Yeah, just in the last year, we've been able to pull together. I think we've been asking for this for years, and this kind of new opportunity with Epic to be able to standardize better. Lab, kind of a multidisciplinary group that we call the Lab Oncology Steering Committee or Biomarker Steering Committee, where we have lab personnel, genetic counseling, our pathology group, the oncologists, and then our team, the genomic oncology group, that all vet different vendors and different tests under their portfolios for on a lot of different markers. So, mostly, what's the clinical utility? What is the, lab? Does it, how good is it at sensitivity and specificity for what it's doing? Is it certified or the right things? What does it add? Do we get those data points? Kind of like Todd and Chris were talking about, can we get the raw data? Are they going to be a good data partner so that we can use that institutionally? And kind of looking at that huge picture and then seeing where the how different things come up and help providers where they need to have the kind of test that they need. So that's been a relatively new process, and we're still working through it. But I think ACCC has had some good education on that, and it's been if for more resources, that was a great one for us.
Yeah, I agree. ACCC has put out some really great resources. I think a couple members of their precision oncology team are also planning to write up a publication for requests for information from our vendors. So I'm excited to see that coming out, and I think that's going to be very helpful for this space. And, just kind of thinking about across the continuum of care. I know, Portia, you're someone who has worked in several different roles in precision oncology, from the clinic side to the side of consulting. Thinking about your experience, what has been some of the biggest implementation barriers that you've faced across these different spaces, and how did you work through that?
Yeah, aside from the PDFs that like Todd and Chris were talking about that just don't make clinical decision support tools very easy, ultimately it was the buy-in, right? Especially for institutions that are just getting started. You already kind of have set pharmacy personnel that are staffing or doing like rounding and things of that sort. And then you add this additional responsibility that is not necessarily a dedicated job description, and you're kind of expected to just roll this into what you're already doing. And as the program grows from a pilot to a full-fledged program, you realize that's just not sustainable and you need dedicated personnel. And so, when I was in clinical practice, that definitely became a barrier for me of just trying to figure out how to dedicate time, often doing things off hours remotely, just to try to stay afloat when I got back to the unit, the next day. And so that's ultimately kind of where the consulting came in, of really identifying the gaps of how I can make this easier for institutions, either for institutions that did not have a precision oncology service or molecular tumor board service, how it could be a benefit to them to make sure that they're still receiving that equitable access to genomic biomarker testing and interpretation for informed treatment planning, but then also for institutions that did have tumor boards, especially during COVID. I mean, people were out. It just really had a lot of holes in the schedule and didn't really have a lot of people to keep up with the flow of the cases. And you might have adjunct molecular tumor boards, on off cycle days, but ultimately helping out with that surplus was really helpful for a lot of institutions, and even myself, and when I was in clinical practice, just allowing us to stay afloat and allowing us to still have access to that care.
Great. Thanks, Portia. I think this kind of naturally brings us to the people driving a lot of this work. And I think pharmacists are starting to play a much bigger role in the precision oncology space. We really are a little bit in the middle between our physicians, our APPs, the pathology teams, the labs, and we can bring a lot of different skills to the table. I think, speaking from my own experience, one of the things that I've struggled with over the years and trying to help out our teams is how we can proactively help identify these patients who need testing. And this is often before we see the patients. As pharmacists in practice, we're often seeing patients more towards the end of the line when they're coming in for their treatments and labs and testing have already been completed. But I wonder if any of you could speak to if you have any unique mechanisms for proactively identifying the patients who need testing and how that looks at your institution.
I can speak a little bit to that. So I know I mentioned that the VA has a lot of great national dashboards and that you're able to really drill down into some of the data. Locally at the Madison VA, we have been working on a process to find a way to kind of tailor that to our providers and provide that information, pull the information for our site on like a week by week basis and identify like these are the patients that are coming through your clinic today that haven't yet had like somatic NGS and would be appropriate if you have tissue or you're going to be planning for a biopsy, et cetera, and trying to get that more directly to the provider. Kind of, I don't want to say hand-holding because it's certainly not, it's stuff that they're aware of and they understand, but it's more just providing that information more easily and having it more readily at their fingertips as they're going through their clinic day and planning ahead for those patients coming in each week. I would say our biggest challenge with that is trying to make sure that it is a more automated process of pulling from those dashboards versus having that manpower be the main thing pulling through there. So we've been kind of working through that. We've been pretty successful in particular with prostate cancer here, and we're working on spreading that throughout our local region and then plan to expand to some other tumor types as well. Eventually, hopefully getting all tumor types covered. So that is one way that we're trying to work on that. And I know that there's some other places in VA that are working on similar processes. Again, we've got all this fantastic data. We've got dashboards, but you have to go to the dashboard and look for it. So how do we bring that to the providers a little bit more readily?
Great. Thanks, Jenny. And so once we've identified these patients and they've actually had testing done, I think, kind of one of our next big pieces in this continuum of care is making those formal therapy recommendations. And Todd and Christine, I know you both have done a lot of work with molecular tumor boards down at Moffitt. I've also been able to sit in and listen on other tumor boards that you consult with on a regular basis and learned a lot from that. Can you provide us any tips or tricks maybe on how we can get started with those processes and what that looks like on a regular basis at Moffitt?
Yeah, I guess I can get the ball rolling on that for us. Again, I think part of an advantage that we've had is like we started doing this pretty early, at a time when maybe others weren't necessarily even thinking about kind of an organized way of getting together and figuring and kind of looking at the molecular biomarker results, the NGS results separately, and kind of bring all parties together and doing it through like the molecular tumor board that we started doing back then when it was kind of all comers, just trying to get everyone together to start thinking about next generation sequencing results. Since then, I think we've gotten more practical in the way we do things when it comes to the molecular tumor boards. And I think of it, I guess, in a few different ways. So one thing that I think helps maybe to answer your previous question a little bit as well. And again, we're fortunate that we have several of us on the precision medicine team here at Moffitt. But one thing that we do is sort of spread out into the regular tumor boards. in the disease areas that we cover, and representing, the precision medicine perspective at these meetings, both in terms of helping with the interpretation and discussion of results that they come back, and in terms of the broader team, and then also, if there's a case like to the prior question, where next generation sequencing could potentially be beneficial for the patient, kind of being there to represent that component of discussion, I think is something that has been helpful, and I think we've all sort of experienced. And then bring it back to like the maybe more formal molecular tumor boards. We now have several kind of more focused molecular tumor boards at our institution. So Chris chairs kind of the main solid tumor molecular tumor board, where we bring cases to those meetings where it's really driven by our team in terms of what cases get discussed when we're reviewing cases where there's potential clinical dilemmas and questions that we're wanting to reach consensus on within our group, but then also kind of spreading that and welcoming others, and having other participants on our molecular tumor board teams. So our precision medicine team, but then also partners from pathology, both molecular pathology and kind of other subspecialties of pathology, genetic counselors, and sort of the medical specialties as well. So we have a solid tumor focused molecular tumor board, and then just sort of, again, a byproduct, I think, of the fact that we've been doing this for so long, that our institution and our other healthcare team members view us as experts in the clinical interpretation of next generation sequencing. So it's sort of just evolved naturally in terms of the questions that we get and things that we're asked to help out with. From obviously, kind of the main view would be therapeutic and kind of decision making based on next generation sequencing results, but it's also evolved into kind of helping to interpret maybe kind of unexpected findings, or kind of weird variants or unexpected variants. So kind of a little bit of a variant interpretation scientist component as well. I think that comes into play on the heme side that I cover as well, where we have the therapeutic questions, but then there's also some questions in terms of helping to interpret individual variants and potential implications for disease. I don't want to say diagnosis per se, but classification. And that's where I think having pathology partners is essential as well. So just kind of thinking from the molecular, like the tumor board perspective, generally kind of integration and kind of getting out into the general tumor boards at the institution, and then having our own molecular tumor boards to handle the more specific questions is kind of the way that things have evolved at our place.
Mm-hmm. I think I'll just add that if you're at an institution and you're starting up a molecular tumor board, or you've been approached about it, there's a lot of different models that and goals of molecular tumor boards, that finding the one that is going to kind of answer the question for the group that you are going to be working with. If it's a cancer specific group, Kevin Hicks at our institution chairs the thoracic oncology tumor board, and a big piece of that is actually matching patients to the large clinical trial portfolio that we have. I also chair a once monthly gyn-onc molecular tumor board that is kind of geared a little bit more for education, as well as a chance to, as we roll out some new things like homologous recombination deficiency, or if we see discrepancies, that it's a chance for us to talk in that realm. And then also it's we also have kind of the way of incorporating what we are doing and being the piece at just the large tumor board. So for neuro-oncology, we review all of the molecular results, including the methylation now. So layering that on with the next generation sequencing and, all the IHC, all the stuff under the microscope, with the imaging, with the clinical story. And so that's a way of doing it. So I think that there's a lot of different models, and there isn't one right one. It's just what is going to work the best for the group that you are working with.
Yeah, thanks, Christine and Ted. That was really helpful. And, I think for some of us who are just getting started with this, getting to that molecular tumor board point is kind of like the gold star at the end of the line. But, also along the way, as we're building our programs and they continue to grow, I'm wondering if anyone on this panel can speak to how you show value or track metrics for what you're doing to really bring this forward to your leadership and administration to gain more support for your precision oncology team. Would anyone be willing to speak to that? Maybe Rachel or even Jenny?
Sure, I can jump in to start with it. So certainly we track a lot of metrics on the national program side through all of those dashboards, but I can speak a little bit to locally because in my role to kind of designate a little bit more specifically precision oncology when we're not a huge cancer center as far as cancer centers go, and particularly in the pharmacy department, there at the time I was the only onc pharmacist, so there wasn't a whole lot of knowledge about precision oncology. So really trying to illustrate the value there. So as we've been able to kind of work on how to use those national dashboards and identify our patients more locally, we've tracked things like how many patients with a particular diagnosis have had appropriate testing. So like if they have a metastatic cancer, that would be appropriate for that somatic NGS. Have we been able to do that? Have we been able to use tissue as our like gold standard for that? And then from those results, how many times have we been able to identify a treatment, and how often can we get the patient on that therapy? And I know in particular, having those recommendations that are very specific to that particular patient's somatic NGS has been really helpful to help get approvals for some of these agents that are otherwise very rare, otherwise quite expensive, and just ones we haven't had to use before. So being able to track those pieces and then bringing that forward to leadership has been really helpful. In addition, also clinical trial enrollment. Have we been able to identify more clinical trials for our patients based on the molecular testing piece?
Yeah, I can second that, what Jenny said, that a lot of the need and the ability to push forward are around quality that we know are guideline-based care. How are we supporting that? How are we ensuring that that happens? And along the research lines about how are we able to help identify patients and ensuring, I think research drives quality in so many ways. And sometimes too, that is actually the hardest part of getting that next layer of testing is testing when it's not always standard or is, a part of that research protocol and not necessarily a part of standard care. So I think that is another way that we can help move the needle.
Yeah, great. Thank you.
I think it's a really hot topic talking about value, because just because you can measure it doesn't necessarily mean that it's necessarily going to be something that you want to measure or that it's going to really be reflective of your true value. I mean, I think about some of the patients where we do the testing and then we don't find something that is actionable, and that is still incredibly valuable for a patient. Perhaps that means that they're going to go on hospice or they're going to go on a different trial that doesn't require biomarker testing. And some of those questions, I think Todd has done a lot of them of, is this actually a pathogenic actionable variant? And so there's a lot of work that goes into it, that it may not lead to an on-label therapy or a clinical trial. And that work can't be discounted either. And so I think, that is why we definitely try to capture those efforts and put them into our clinical notes. But I think it's very tempting to say, well, how many patients got identified for trials, or how many patients, that you got off-label therapy for, like, what is your success rate? All of those things I think are really important. However, we have to look at we don't actually control a lot of that. I can't control if a patient is actually going to decide to go on a trial or if an insurance company is going to give us the drug. So I think it's kind of being realistic about this. And I know that, I think ATOP has a meeting coming up, and there's a pre-meeting session that is really focused on talking about value and what should we be looking for. So I think it's a very good question, and it's a very hot topic.
Yeah, thanks, Christina. And thanks to all of you for the great discussion on that. I think that does bring home a really important point that, not only can testing tell us what to do, it can also tell us what not to do. And we need to keep that in mind with every single one of these patients. So I think we're getting close to our time here, and I want to thank everyone. But I'd really like to wrap up with a final question, and maybe Portia, I'll push this one back to you. But why do you think it's essential that pharmacists serve in this role, and what unique value do pharmacists maybe bring compared to other providers in healthcare right now?
Yeah, I'm so happy that you asked this question because it really, I guess, for lack of better terms, grinds my gears when I see these schemas of the tumor boards, and you have a medical oncologist on there and a nurse and research and all the things, but you do not have a pharmacist. And I'm like, the institution I came from, it was a pharmacist-led molecular tumor board. And I say that because we bring so much value. You can easily take a gene or a biomarker and match it to the drug, but is that appropriate in a clinical context? Are you taking the full patient into consideration? Their psychosocial factors. Are they able to withstand this treatment? Can they get through the clinical trial? And I think, for an example, we had a medication that was for like a KRAS G12C, and it was oral, and the patient was NPO and tube dependent, and the provider wrote it off of like, well, we can't give it. And I was like, absolutely not. We are, just so resilient as pharmacists of finding different formulations, and we were able to compound that to go via tube, and the patient was actually able to receive the medication, come out of the ICU, and make it to Christmas, which was their goal, which just was just such a shining star, and just an example of what we did as pharmacists on the tumor board, and what was said that could not be done, and we definitely made it possible. Something so simple for us as far as formulary change, but it made all the difference for the patient. So we absolutely are not adjacent. We are absolutely central to tumor board services. We're central to precision oncology. And as the drug experts, I think that, we've definitely paved our path, and we've shown our value.
Yeah, well said, Portia. I love that. So I just want to thank you all again for being here today, for sharing some more information about your precision oncology practice models. As we learned here today, there are many ways to deliver precision oncology care to our patients. And however, regardless of the model that your institution is using, HOPA is a strong proponent of integrating the oncology pharmacist into the care team and workflows in order for our patients to have the best possible outcomes. So HOPA's Precision Oncology initiative is really aimed at providing the oncology pharmacists with tools, resources, education, and training that they need to get involved at their own institutions. And we hope to have more resources that are going to be published soon. So in the meantime, don't hesitate to reach out to HOPA at research@hoparx.org if you have any questions about the content presented today, or even additional questions for our panel members. So thank you so much for your time, and have a wonderful day.